Good afternoon, everyone. We're going to begin now. Thank you for joining us for this presentation. We will be going over details related to the 1915C Comprehensive Home and Community-Based Services Waiver, Proposed Amendment 05. My name is Lisa Kennedy. I'm with the Waiver Unit here at OPWDD. And we also have Kate Marley, our Deputy Commissioner, OPWDD Division of Person-Centered Supports. She will be presenting some slides, as well as Donna Cater, Deputy Director from the New York State Department of Health Division of Finance and Rate Setting. Okay, so the purpose of today's session, we are going to review the proposed Amendment 05 of the 1915C Comprehensive Waiver. And the goal of today's session is to help stakeholders focus their review on the sections of the waiver that are most important to them. I wanted to mention that we are in the 5th year of the current 1915C OPWDD HCBS Comprehensive Waiver itself. So when Amendment 05 takes effect on July 1st, 2019, we will only have 3 months left until the waiver renewal on October 1st, 2019. Every 5 years, New York State submits a waiver renewal application to CMS. So after this Amendment 05 is approved, we will move forward with the renewal process. Today's topic, helping you as stakeholders find the actual waiver language. It is posted on the OPWDD website, and it is also available in hard copy at OPWDD's 14 regional offices statewide. The public comment period, we will go over information as to when it starts and how you can submit comments. And most of the presentation will center around the overview of changes related to CFCO, which is the Community First Choice Option State Plan, and terminology changes for care management, as well as some rate setting proposals. And as I mentioned, the Waiver Amendment 05 is available on OPWDD's website, and the link is here. And yes, I know that several of you have asked if the presentation is going to be available after today's session, and we will be posting it on our website. And we will, I believe, email it out to all registrants on the WebEx as well. And also, as I mentioned, the Waiver Amendment 05 hard copies of the waiver, they are available at all 14 OPWDD district offices. The public comment period. The public comment period began on March 27th, so this past Wednesday, and will continue for 30 days until April 29th, 2019. Comments can be submitted by regular mail at the address listed here or by email. Once your comments have been reviewed and any necessary adjustments have been incorporated, New York State will submit the amended waiver to the Federal Centers for Medicare and Medicaid Services, or CMS, known as the acronym, for approval. Additionally, at the close of the public comment period, OPWDD will compile a response to public comment document that will also be posted on the website. We will take into account comments received and will note any additional changes based on the comments. Okay, and now we're going to get into the overview of changes itself, and I'll hand it over to Kate Marley.
Good afternoon, everybody. First off, I wanted to sort of talk a little bit about why we need to make this amendment at this point, given that, as Lisa mentioned, we're so very close to needing to renew the waiver for the next 5 years. One reason is New York State is getting ready to implement Community First Choice Options, CFCO, which is a program that takes a number of services that were only available through the HCBS waiver, ours and other waivers, and then makes it a state plan benefit. So we just want to make sure that we're aligning our waiver program with the program that's available through the state plan so that there's a very seamless transition for everyone and everybody has the same rules of engagement, whether they are receiving the service through the HCBS waiver or through the state plan. We're also making minor language changes throughout to reflect the implementation of IDD Health Home Services. That's not really significant changes, but we're making terminology changes, for example, the reference to care manager, et cetera. We also had to make technical rate changes in this document, and that was one of the major reasons we had to do this. We had certain programs, rate programs that were sunsetting at the end of June, and we are asking CMS for an extension on those. So Donna Cater will be here to talk a little bit about those changes. So let's talk a little bit about what CFCO is. As I mentioned, it is a state plan benefit. It is a benefit that is available of services that were previously only available to people who are enrolled in an HCBS waiver. And with the movement of those services to the state plan, they will be available to a wider array of folks in New York State. One of the major advantages of a state plan versus a 1915C HCBS waiver is that the state plan has no wait list. And under the state plan, a wider array of people can access the services. So the changes that we are making here, we'll get into in a little bit more detail, but it's really to make sure that we have a consistent program and administration, whether the service is funded for a person under the HCBS waiver or whether it's going to be under the state plan. It should be absolutely seamless to a person and no interruption of services. We have a more detailed presentation that is available on our website. We've recorded and presented a PowerPoint. So today's session, we really want to focus more on the waiver. We invite people to at the link below to view the fairly short CFCO overview, which will give folks more information on that topic. So this slide basically outlines the services that are both part of the HCBS waiver. So those are existing services that folks who are enrolled in our waiver could access that are also part of the state plan. And so we're making changes throughout our waiver for these services to make sure they align with the federal requirements. And what we provide here is the service, what the major change is, and the page number in the application for you to review the language. But let me just walk through those. So for environmental modifications, there's really no change in the service definition. The change is that there previously was a hard cap every 5 years for $60,000. So that meant it could not be exceeded. That's what the term hard cap means. Now, to align with the state plan, it is an annual $15,000 limit that can be exceeded due to medical necessity. So it's a very different approach to administering the service, and we want to make sure that we are consistently allowing costs to exceed medical necessity where necessary, both on the state plan and the waiver side. Very similar changes for vehicle modifications. The service does not change. It's still the same service. The limit is changing. It was in our previous waiver a hard cap for every 5 years of $35,000. It is now $15,000 annually with an ability to exceed due to medical necessity. Assistive technology, same thing. We had a hard cap of $35,000 every 2 years. It is now $15,000 annually, again with the ability to exceed with medical necessity. Community transition service, it is a service that I think is an important one for us to have, but it has never been used with great frequency, and there is a change here in how it is organized. So in prior waivers, we had community transition services, CTS, as a single service that included costs and supports to allow a person to move from a certified setting to a more independent community setting. So what we are doing here, again, in alignment with the state plan option of CFCO, there's two separate services. So CTS used to include moving assistance and purchase of supplies, et cetera. And now we're going to have two services. One is community transition service, and we will have a separate service for moving assistance. So it isn't really new services being available. They've always been available. We just categorize them differently now. And the overall expenditure allowed for these types of supports is now increased. As we move forward, we will have $5,000 for CTS and an additional $5,000 for moving allowance. So previously, all those supports were in one category, and there was a $5,000 limit. So the other change, and we'll go into that in a little bit more detail, is community habilitation. Community habilitation will be available through our waiver, and for people who are eligible for CFCO, they will get that service through the state plan. Again, same providers, same payment rates, same program rules, so it really should be very seamless for people whether they are accessing the service through the state plan or through the waiver. The service definition is not changed. We are, however, realigning our fees to align with other systems. We had 3 other systems have an upstate and a downstate, so we will be aligning with those. And Donna Cater will be speaking a bit more about that. I just wanted to note that not only is the Community Hab service available through CFCO, it will also be available for the new children's waiver. And so we wanted to make sure we were consistently reimbursing and organizing reimbursement across all those 3 venues, since we will have providers that will likely be delivering Community Hab within our OPWDD waiver, maybe delivering Community Hab through the new children's waiver, and also, of course, through the state plan. So the next series of changes relate to the implementation of CCOs and our IDD health homes. As everyone knows, that transition began on July 1, 2018. The language changes we are making here, I would not categorize as substantive, but we are changing the terminology that we use. For example, eliminating the use of the term MSC because that program has closed, and talking about care management versus service coordination. So that is throughout the waiver, but most importantly, Appendix D, which begins on page 168, focuses most directly on those that service area. So the next sort of series of changes that are happening relate to rate setting.
I have that.
Yes, you may.
Good afternoon. I didn't get my copy of the PowerPoint printed out. I guess it's Friday and raining, and my staff decided to send me on my way without anything. So the rate setting changes, albeit when you first look at them, you're going to think that there is a lot of changes. There really isn't. Really what we've done is we've updated it to take out some of the old language and sunset certain rate setting methodologies on June 30th. Things that we are no longer using, monthly ResHab, for instance, that'll be taken out because we haven't done that now since 2014, and it just makes it very difficult to review, so we've taken things like that out. The proposed amendment extends the current methodology from 21 to 23 for higher needs funding. I believe that one said it would sunset as of 6/30/19, and we need to make that change because we are going to extend our current methodology using the DDPs for higher needs. Current methodologies for self-direction, they follow right along with all of our methodologies, so anytime we make a change to our current, including taking out sunset language, we have to update those self-direction pieces.
Right. So the current methodology of using the DDP was set to sunset on June 30th. It's just a technical change to extend that several years.
And then the other one of the other big changes that we made was revising the occupancy calculation for IRAs that we had previously included. Somehow, when we included it in 2014, and then when it got moved over to 2017, 14, 15, 16 were fine. Then 17, there was a slight change in the wording that happened. So we are changing that, and that's to a benefit of most providers. So you would want to focus in on that one. And then the review of costs associated with overnight respite
may be evaluated at a later date. So that was language that, again, there was a previous language that we would, by July 1, be making a change in that methodology. We're simply extending that time frame.
And that's the simple rate changes. Like I said, most of them are really just taking out old language that is just taking up a lot of space and confusing providers' review of the language. And then there was the two other changes, and that's it.
So the organization of the document is, for those of you who have already reviewed it, is not changed. The first several hundred pages is the main body of the application, and we provided the pages within that where changes were made. The final 80 or so pages is the rate setting addenda, and that's where the more technical changes to the rate setting methodology are happening. But again, I would categorize most of them as really non-substantive, but necessary to make sure that we continue with our current methodologies and to align with CFCO. So we're going to open it up for questions and discussions, and we're going to take a minute to take a look at those. I just want folks to know that we will be posting this PowerPoint and a recording of this on our website. We will also distribute the PowerPoint to folks who have registered for this session. And of course, feel free to send questions or comments to the People First address here on the screen. And with that, we're going to pause for just a minute and take a look at some of the questions. Okay, so we had a couple questions we can get into. There was one question related to the 1115 and our move to the 1115. So that is entirely correct. We had talked about the 1115 in discussions with CMS. They advised that we can move to the 1115. That will not happen immediately. However, we need to maintain our 1915C. So what we are doing now is making sure that our 1915C continues to cover everything it does with no impact of some of the sunset language that we had with June 30th, and we will be renewing later in the year for October 1st. So it's not that at some point we won't be using the 1115, but the immediate need is to make sure we're maintaining our 1915C services. Another question related to the exclusion of budget authority from the CFCO, Community First Choice option. In the CFCO slide deck, we include a link on the very last tab to the DOH webpage that has pretty extensive materials on CFCO, including a copy of the state plan amendment. That state plan amendment was approved by CMS, is available on the DOH website, and clearly states that the SPA does not include budget authority. So just to explain what that means that we keep budget authority within our 1915C waiver unchanged, and that people who self-direct their services will continue to get, for example, if they self-hire staff to deliver community have within their budget, that stays with the waiver. With the current rules, no change. And that's also explained in the PowerPoint that we have on our website.
We do have some additional questions. Regarding AT and EMODs, what information will be required to show that an EMOD is medically necessary after the $15,000 cap?
So we are working jointly with the Department of Health because obviously as a state plan benefit, it's available across, but we are not thinking that the materials and requirements will be any different than they are today. So you will need clinical justification. You will need project specs, for example, particularly for EMODs, and those need to be reviewed and evaluated and approved prior to billing. So it should be very much the same process. What differs is the ending of the hard cap.
Do we need prior approval for any project/equipment that exceeds the $15,000 cap?
So yes, that's a very good question. So the process will be, and currently, let's be clear, for any project like EMOD or AT, there is prior approval required. So prior approval is not a new thing. That happens today for all projects. There will be additional review for things above cap, and that is with the New York State Department of Health for all populations. But of course, OPWDD will work very closely with them for the final review of costs that are over that, the limits that are specified.
Where can providers find rates on CFCO?
CFCO rates were published for all providers on the where they would go to see those rates, which is on the mental hygiene webpage. So you should be well aware of that as a provider. The proposed rates were published there.
And they also were published with all of the CFCO information on the DOH side. The mental hygiene rate setting side is also DOH, but it was published there. It was published also on the other side with all the CFCO information. So it was published in two places.
We did have another question come in. Will CFCO state plan enrollment be automatic?
That's a great question. So essentially what we're working on now is that in fee-for-service, it should be very, very seamless. We are identifying those people who are eligible for CFCO and those people who are not. And again, we have another slide deck that outlines that. The process will be exactly the same, and the billing system will basically decide how the service is categorized for those folks who are in fee-for-service. So there's no need to separately enroll in terms of being a provider or, in fact, the person. It really becomes just a part of the payment flow, if you will. So it should be very seamless. The only difference will be for people enrolled in managed care, where that will become a managed care benefit. But that will be, so that would be the one sort of administrative change in how payment and registration will happen. And again, there's more information on that and a sort of high-level walkthrough available on our website.
When do the changes to the EMOD cap changes take effect?
So we are asking CMS for a July 1, 2019 approval. So following public comment, assuming there is no changes due to that, we will submit. And I assume we would be approved by CMS, and those would take effect July 1.
Will OPWDD be involved in the EMOD, VMOD determination, or will it be the Department of Health handling those determinations?
Very good question. So OPWDD is absolutely going to be involved. The DDROs, the process will continue exactly as is. You're going to be working, providers will be working with individuals and families through the DDRO. And then if there is a cost over cap, OPWDD will be working with the Department of Health on the final approval of those projects.
Will the rate changes be communicated to the agencies?
The rate changes in terms of community habilitation, which are the only rate changes that are happening, and that affects just a few counties. Most counties are pretty much the same. Those have been communicated to providers through the normal course of business. They are not yet in effect, of course, because that will happen on July 1. So there was a question about the lack of need to enroll related to for people who are in managed care. So I don't want to get into too much detail here because we do have a separate presentation on it. But what we had talked about was for people who are not in a managed care plan, so they have not voluntarily enrolled in a mainstream managed care plan or health care plan for their Medicaid services, and that is the vast majority of people that we serve are not associated with a managed care plan. Those folks will continue to have their services billed through eMedNI as they do now, and there will be no need to separately enroll the person or for the provider to separately enroll to be delivering, for example, let's say Community Hab, either through the waiver or through the state plan. It should be very transparent. There is a difference, however, for providers that are delivering services to a person who is enrolled in a managed care plan. They will need to sign a contract or a single case agreement with the managed care plan for the payment of services. And we are working with providers now about making certain that they know which plans are associated with the people who they serve today. And there is a community care managed care community of practice that is available and doing sessions with providers to help with that readiness activity.
Is the service limit a service limit within the 5-year period, or can a person seek up to $15,000 more frequently?
Yes, so the new limits, and this is part of the, very much more flexible than previously, it is an annual limit where noted. So CTS and moving assistance never has been annual. It's always been a single event, and it still is. But for the other ones, eMods, VMods, and assistive technology, those are annual limits. And yes, multiple requests can be submitted. We would strongly recommend that if there is a greater need than the cap that is listed, that people approach the need for medical necessity rather than engage in serial requests. But of course, there would be no exclusion of that.
Are home health aid services now available through the amended waiver, or will they be?
So I think this is a question going back to community first choice option. Think of it this way. There's a state plan bucket, if you will, or group of services that include things that were formerly, for example, in our HCBS waiver. Those were sort of copied out of our waiver and put into the state plan. There were also services like home health aid services, personal care services that were available to the state plan and are now considered part of CFCO. Those services will be available and are available, those state plan services, to people with IDD if approved, but they are not part of our HCBS waiver. So the process for obtaining approval for example, personal care is going to remain as it is today. If you are in fee-for-service Medicaid, you're going to be working with the county, and OPWDD will continue to be the entity for those services that were part of our waiver. So the ones that appear in that list of services that talk about CFCO in the waiver, OPWDD will remain the entity with whom providers and individuals work for access to those services in fee-for-service.
Are we going to receive revised guidance that includes the new eMod AT limits?
So we are working on reviewing all of our ADMs for any service that is affected and other guidance. So our objective is to keep it absolutely consistent, whether at the end it is ultimately a waiver service because, for example, the person is not eligible for CFCO, or whether it is a CFCO service. So yes, we are working now on that guidance, and it will be published and available.
In regards to CFCO, is a person eligible for CFCO simply by having Medicaid? If not, what is the eligibility process?
Okay, I will really strongly want to direct people to the PowerPoint that we have available on our website because it does walk through that. And it's not very long, and I think will be very helpful for understanding this. But there's 3 basic requirements. for CFCO eligibility for the person. Obviously, they have to be Medicaid enrolled. In addition, they have to have a level of care, and that could be ICF level of care, that's our folks. It could be nursing home level of care, or it could be hospital level of care, but you must have institutional level of care. You also must live with your own or your own or family home. So, for example, people in an IRA or a certified residence of any kind are not eligible for CFCO. In those instances, you would continue to get the services that you're eligible for through the HCBS waiver. The final category is you must have Medicaid by regular rules, and that means that there is no special budgeting for your Medicaid case. Most frequently for our population, that might be children where we waived parental income when establishing a person's eligibility for Medicaid. So it's essentially you must be ICF level of care or another level of care. You must have Medicaid by regular financial rules, and you must live in your own in a community apartment. Those are your own or your family home.
We're just going to put it on mute just for a moment to sift through a few more questions.
Okay, we have gone through the questions, and I think we pretty much addressed most of them. There's some more detailed questions on CFCO. Really, the purpose of this webinar was to make sure that people understood where and how to review the waiver during this public comment period. We will look at these questions, and it may be that we want to publish a Q&A in more depth. On CFCO, we will certainly take a look at that. In the meantime, the questions and answers, this session is being recorded and will be available on our website, and we will distribute the PowerPoint to everyone. I'd like to thank everyone for taking time and joining us this afternoon. Enjoy the rest of your day.